Well, I think people will probably wander in, but we'll get started. So, my name is Klafter. I know most of you. I practice in Cincinnati, Ohio, and also in the New York, New Jersey area. I'm a general adolescent and adult psychiatrist. I'm also a psychotherapist and psychoanalyst, and about a third of my career for the last 25 years has been training therapists and psychoanalysts at various stages of their professional development. So this talk is called Validation is Not Empathic, Empathy is Not Validating. So I'd like to start by talking about why validation and empathy get confused, which will bring us to why I prepared this talk in the first place. By the way, I prefer to be interrupted as I go along. If I think that the interruptions are going to hold us back from the talk, I'll be responsible to move us on, but most people's questions reflect other people's thoughts, and I don't mind discussion as we go along. We'll get through all the material. So the reason this talk exists is that I see empathy and validation as being routinely conflated with one another. And also therapists who believe that therapy heals through love and kindness in the therapy relationship that they've never received before in life. There are a lot of therapists who really do believe that. We've had some participants in talks so far asserting that view of therapy. Supervisees who believe that if they disagree, that means with their patients, it will invalidate the patient's experience. So they're really afraid to ever disagree with a patient. And I think that this results in a failure to help patients see and change the most unlikable, problematic, and maladaptive aspects of their personalities. I think that if we are so focused on always being in agreement, always affirming, always validating, it really limits our ability to work in areas that are a lot less pleasant and a lot less easy. And all of my patients have a lot of areas like that. So just another working observation about validation, I think it often feels good to the therapist, whereas deep empathy, it often feels unsettling. And as we go further in the talk, we'll explain what that means, that empathy can feel unsettling. If that sounds counterintuitive or oxymoronic, it might be that you've been operating with a definition of empathy that is sort of conflated with validation. And I think validation is easier than empathy in the therapy setting, actually. So let's start with defining validation. Start off by saying that, I'm going to give you a psychoanalytic definition of validation. However, if you search the literature, the psychoanalytic literature, you will not really see validation treated as a psychoanalytic idea. If you do a search of all published psychoanalytic journals on the psychiatric, the psychoanalytic electronic publishing platform, the PEPWeb, the word validation is mostly used about research, about validating, the validity of a concept. Like, how do we know that the Oedipus complex is a valid construct, or how do we know that outcome research is valid? Excuse me. So the few places where validation is described, it's not as an official psychoanalytic term, it's just used as an English language term. And what it means is confirming the patient's perception of external reality. That's actually what validation means. I think that fits. Now, I think we think of validation as being something that has a deeper emotional resonance or feeling to it, but actually the situations where validation is helpful, the reason that the patient needs help is they're often doubting their judgment or their perceptions. And it's very unsettling. If we think of just, common experiences, I'm sure all of you have had a situation where there's a Shabbos guest at your house who says a number of things that are like outrageous and crazy. And you just sort of wonder, like, am I crazy? What's going on here? This seems so far-fetched or outlandish. And you look to someone and say, like, are we crazy? Is he crazy? You're looking for validation. It's actually a very normal human need when your sense of being sane or right is challenged. I think it's used when confidence in that perception is compromised. When someone is doubting themselves, they seek validation, you may offer validation. We certainly have patients that are compromised in their ability to receive validation. Most of us, when we're challenged, we seek out friends and ask them, did you hear that? Did you hear what he said? And that's a healthy, normal human thing to do in personality functioning. There are people who have been trained in their abusive childhoods to doubt their common sense. And those are people that actually won't seek out validation. They would feel inhibited from doing so. I will tell a story that I tell pretty frequently when the principals involved are nowhere near the venue. This happened a long time ago when I was living in Philadelphia. We had a family in our house for Shabbos lunch, and my wife had made very large chocolate chip cookies for dessert, and everyone got a very big chocolate chip cookie. And the daughter of our friends said, "That was so yummy, Mommy, can I have another cookie?" And her mother said, I would love to give you another cookie, but there aren't any cookies left. But right in the middle of the table, there was a plate with a huge bunch of cookies. So this little girl looked at the cookies, looked at her mother, looked at the cookies, looked at her mother. She said, "There are really no more cookies?" She said, "No, there are no more cookies left. All the cookies were eaten. There was one for everybody." She looked at the cookies again, looked at her mother again. She said, "Okay." And then she went away and played. So, and this is not that unusual a story. Another story that I heard from a patient is that when the ice cream truck in the neighborhood would come by and the bell was ringing, her mother told her that the bell means that they're out of ice cream, which is an interesting story. So someone like that is going to be really impaired in their ability to seek out validation. And they do really doubt their common sense and their judgment. I think that one of the outcomes of therapy should be an increased confidence in one's common sense. But we will always have our reality sense tested. I mean, that's just part of human experience. That's just everyday experience. So validation is stabilizing. It's not an interpretive intervention. It's a stabilizing intervention. And I think that's sort of self-explanatory. I think that's a good example. The question is, if people feel that they're doing something strange or wrong, and sort of educating someone that actually the experience you're having is quite normal, and many people have this experience, I think that's actually a very good example of validation. And I think that would be a ubiquitous aspect of most therapies. The patients feel there's something so strange and odd about them that makes them unappealing or unacceptable, and it's something that might be a universal shared experience. And so, yeah, I think that would be an example of validation also. Yes? So the question is, does this apply to perception of internal reality? Maybe spell out an example of what you mean with an.
Like when a person's judgment about their internal state is compromised, they were never supposed to recognize anger and anxiety.
Right. So if you were never taught to recognize that you're angry, I actually don't think of that as validation. I think of that as getting closer to empathy, or the container-contained theory of Bion, and we'll talk about that. But no one feels like I do because I'm so weird. That also might really inhibit your sense of internal reality. When you believe there's something so strange or problematic about your experiences, you are inhibited from delving into them or acknowledging them more. And now we're getting into a little bit of semantics, but I think we'll get back to your question when we get toward empathy later, and we'll see which you're thinking of. So, who requires validation? People with trauma histories often require a lot of validation. Why is that, by the way? Why do people with trauma histories require a lot of validation? They never got validation growing up, and just to further what you're saying more, what it means that they never got validation is their common sense and their belief in themselves was greatly undermined. Usually that's part of the abuse. Are people familiar with the book Soul Murder by Shane Gold? It was a classic at one time. It's and my boss, Malky Schick, says it's a great book. So to sort of summarize, one of the theses of the book is that profound abuse, which would correspond to what we're talking about now as developmental trauma or complex PTSD, but pervasive trauma that goes on over a long period of time. The three elements are, number one, bad things are done to the child and adolescent. Things that should not be done to children are perpetrated against this child. Number two is that good things that all children need to be healthy, they're deprived of. They don't receive those, good things, which would include validation and number three, which is the most invalidating component, you should not expect that any of this should have been any different. Nothing about this is unusual. You don't have the right to anything different from this. Those are sort of three elements of profound abuse. And that sense that you don't deserve anything different, you don't have a right, you don't have a taina, is really something that sets someone up to be unable to really trust in their judgment of their experiences in life. People with dependent character organization, or like dependent personality. Why do people with dependent personality disorder have trouble with validation? Why do they need a lot of validation? They're terrified to disagree. They're terrified to assert their independence. Often, if you see someone, we've all met patients with dependent personality disorder. We're also, part of a community that has a culture that really, autonomy has sort of a different view in our culture than it does in other Western cultures. So dependency and enmeshment is culturally, has different expectations in our communities. One way to think about dependent personality is that people are so inhibited in their assertiveness or their independence or their aggression. That's one of the reasons they can't break out of those dependencies. Avoidant personality styles. Why do people with avoidant personality have trouble with validation? They're so terrified of criticism and scrutiny, and the basis of being terrified of scrutiny and criticism is often like this deep sense that, my ideas, my views, my being, my thoughts, no one is going to agree with, no one is going to take seriously. They're just ready to be sort of devastated or humiliated by people. Severe self-esteem pathology, fear of anger and aggression. I think the summary would be patients who are reluctant to see or acknowledge things which will cause any interpersonal conflict or complications. If that's sort of like the organizing basis of someone, then those are people that will have a lot of trouble with the validation because they will be afraid to acknowledge or see something happening that is going to, if they would acknowledge or see this, there's going to be trouble. There's going to be difficulty. So it's easier to not see it, not think it, not know it. So what validation is not? So this will be a little bit paradoxical. I'm happy to invite some disagreement. Validation is not empathy. It isn't empathy. That will become clear as we go forward. But it can make a patient feel accepted. So that's one of the easiest reasons to confuse it with empathy. It is not agreement. Okay, agreement with a patient is not validation. It might confirm the patient's sense of things, though. It's not reassurance, even though it might be reassuring. You know, it might end up being reassuring, but you're not aiming to reassure someone when you do this. You're trying to help them hone their judgment and their discernment and their insight. And it's not a relational stance. I think this is the most important one. But I see therapists getting trapped in this. I see therapists getting trapped that, like, this has to be sort of the organizing structure of the whole therapeutic relationship, that it has to be a validating relationship. Any questions or thoughts about this? Yes?
From your understanding, why do you think that's happening, that therapists are becoming trapped in that? What is seriously your thoughts on that? Why is that the case?
Well, the question is, why do therapists get trapped in this? I don't think this is new particularly. I think this is there's a lot of reasons why. Number one, there's a reaction to what was sort of a caricature of certain types of therapy that are so austere and sort of an aloof stance. It would include like a caricature of classical psychoanalytic posture. It would include cognitive therapy, where automatic thoughts are being corrected. And of course, those therapies can be done with a lot of warmth, but they can also be done without warmth. And so there are some therapies that kind of emphasize the corrective therapist being right aspect of the therapy. Number two, I think the normal human instinct when someone comes to you in distress is to be kind, supportive, and not critical. You know, and that's just sort of like a normal response. So that includes therapists also. Number three, I think we hear a lot of stories about patients feeling harmed or insulted or damaged by their therapists, and we don't want to perpetrate that again. I think we might discover that some of those stories are, you know, really kind of distorted, and that it's the patient's experience. If we were there as a fly on the wall, we might not have seen it that way. And, you know, there are many situations that if you are confirming and accepting, you'll be helpful. It's not like that's never the right thing to do. And I think that it's difficult to disagree with someone or tell someone something that's going to cause them distress or make them possibly hurt. I think that's a difficult thing to do. Alana? So the comment, it's actually a better answer than the ones I gave, I have to admit, but I wasn't ready for Frady's question. So patients that are very narcissistic, aggressive, and are going to be highly reactive, we get intimidated we walk on eggshells. It's not even conscious that we're doing that. Like, we are very, very cautious. It's very frequently that I will have a supervisee and I will suggest an intervention, and the supervisee will say, there's no way that I could ever say that to this patient. Now, sometimes they're right, sometimes they're wrong. I do think actually patients are capable of hearing much more from us than we realize, and as we get more experience, we realize that. But sometimes they're right, and also, I mean, the therapist has to be comfortable with it. But I usually find that my supervisions, I'm helping people say more that is going to be less agreeable, and I'm usually not having to rein in supervisees. You, I don't know your name, and then Yitzi. So I'm just repeating comments for the recording. So the comment is fear of the patient's anger and a fear that it's going to really like disrupt the treatment and the patient will never come back. And you have to be liked by the client at all times. And you said that they come back next week anyway. Someone didn't come back at some point though, right? You didn't never lose a client with this. Never lost a client with this? Okay. All right. So more skillful than me. Yitzi.
I think also that when a therapist hasn't worked out for themselves, they're asking when they're invalidating or empathic, or might assume that the entire stance of the therapist is invalidating. I find also kind of surprising also that it gets trapped in that.
Okay, so the comment is that some therapists that really have this confused, that they don't understand when they're being validating, when they should be validating, that they don't have this worked out for themselves. I think someone should give a lecture on this. That there's a need for a lecture on this, clearly. In the back.
You mentioned that, and like analytic work where there is more of an observing,
Just want to like a caricature of analytic work. There was a caricature of analytic work that it's like that. Yes.
Right. Even in that caricature, and this goes back to the question earlier, you do regularly validate internal reality. I mean, to say something that's really a reflection / validation of, well, you were devastated by that was horrific whatever, expectations to continue on, per se.
Right. So the comment is that even in psychoanalytic work, in classical psychoanalytic work, there is validation of internal experience. If it gets into semantics, then it's not important. The distinction I want to make is that when someone doubts external reality, they're coming to you for help because, like, I think that this weird thing happened. I'm not sure. I don't want to overjudge it. The patient has a sense that this is probably a problem, but I'm afraid to call it a problem. I'm reluctant to call it a problem. Please help me. Is this really a problem? When it's internal reality, I don't think patients are saying, maybe I feel angry. I'm not sure that I feel angry. I think they're saying, I'm not angry. I'm not angry at you. I'm just frustrated at the situation. Or, I'm not attracted to him. I'm just imagining that anyone else might be attracted to him. They're really disavowing. So I think there's more of a disavowal of internal sense, and I think therefore the work is more jarring when it's about internal reality. I think ultimately in the long sweep of therapy that someone feels much more at peace and confident if they're confident in their internal feelings. But each little moment, like each microscopic intervention, it has like a different structure than when it's someone doubting their judgment. That's why I'm making a distinction. Yes, Menachem.
For me, just for me to be able to understand how you're defining this, going back to the non-emotive, would the validating response have been, yes, you can have the cookie, or I see you really want the cookie, but we're not having more cookies, or it looks to you like there's cookies, and you're confused why I told you there's no more. Like, which one of those is the validating response?
Okay, so the question about the example I gave where a mother tried to succeeded in sort of gaslighting her daughter and making her doubt her perceptions that there are cookies on the table. So I think none of those things would be validating. And she didn't even, I'm giving this example, it's not even about validation as much as the kind of upbringing that could set someone up for not having confidence in their perceptions. I think the normal parenting response would be, I think that one cookie's enough, and I don't want you to have another cookie now. I think it won't be good for you. I'm afraid you won't feel well if you have another cookie. And not make the child doubt her lying eyes that there are cookies in front of her. So she's set up to not have confidence. Now, that won't be the only experience, I have a feeling, that this child is going to have. There will be many things where the mother thinks that, the right intervention is to, prevent the child from clamoring for something, and that's going to be an easier intervention for her. But so this child is being set up to doubt her reality. I I don't know if validation is the issue there. Did I answer your question, or? Okay.
My question, again, not in terms of what the parents should do, but what would validation look like? Just to understand how you're defining validation.
Well, these cookies are yummy and you'd like another cookie, and there are more, but I don't want you to have another one. That would be validating. You know, there's nothing wrong with wanting a cookie. That's human nature. You see that there are cookies. You're just not allowed to have one. I think that would be that's what I think would not have set her up for this kind of problem that I anticipate she'll have. So when validation becomes harmful, all right, when it's demanded, when patients demand to be validated, they don't need to be validated. They know what they believe, and they demand that you confirm their belief. And the question is, I wonder, you seem to have a very well-formed opinion about this, and I wonder why you want me to validate it, or I wonder if you're anticipating that I disagree with you, like I just wonder what's going on here. I think that would be the more correct stance in general. Frady?
I have oftentimes come across with my clients that they need permission from me to say, be, do, whatever the case might be, and I'll point it out to them. Like, this is what's coming up for them, and I'm just curious if that could be part of
Yeah, so the comment is when patients ask permission, can you, like, permission to do or say or think what, for example?
I'm trying to think of an example, but it comes up frequently with my clients because they haven't had that model for them, and they haven't had the experience of being able to have a self and think for themselves and whatever the case might be. I can't think of an example offhand. It comes up frequently where they're turning to me, like, to ask permission. Like, can I
Right. So if a patient is turning to you to ask permission, I guess the reason I asked for context is it's a judgment call about whether you feel you're being co-opted into something that seems unnecessary or contrary to your judgment, or whether it's really someone struggling with their opinion. I think that's sort of, so if you really think someone is struggling, I don't know if they're asking permission. Ultimately, we want to help them see that things they know very clearly, there are mechanisms in their mind that cause them to doubt those things. That's what you want to help them see. But so it's really a judgment call. So when something is demanded, this to me is different than being demanded, what you're describing. This is someone like, your sense is the person is struggling. When patients dig their heels in and, just demand something from you, and it doesn't make sense. Like, why do you need this from me? I really don't understand why you need this from me. If that's your feeling, I think it's probably helpful to articulate that you're confused why they need this from you. Yes?
So, could you discuss this with the example of trans population? Because that's where a lot of the demand is coming. There can be exploration of what's underlying and why.
So the question is to discuss this in the trans population, and there's an underlying demand to be validated and why. Let's save that toward the end, but I will say that I agree with your observation, but I'm just afraid that it's going to be a really deep and fun rabbit hole to go down with everybody. In the second row, yes.
I'm curious, when we spoke before with reassurance, how validation and non-reassurance, and I feel like it kind of falls under this right here where it's harmful. I feel like a lot of times there are people that are reassurance seeking, and by giving validation, in some way like my validation that you're giving it to someone else, to a client, or whatever you call them, can be feeding into this reassurance seeking mentality. Is there a way we can break that?
So the question is people that are reassurance seeking, in other words, they're constantly asking for reassurance, and can you pull back from that? So I think that the way I would, again, you're going to need to have clinical material to really know exactly what you mean, but I think in general, someone that's reassurance seeking probably does have some underlying problem with their judgment. Now, if you feel like the reassurance seeking is getting annoying for you, which it really does often, then you will speculate that this is probably annoying for everybody and they need help managing this urge to be reassured because it's probably causing problems in relationships and making them annoying. And you also need to figure out, like, what is structurally a problem that they are so doubting themselves all the time. So, I think that you will have your countertransference of annoyance to deal with. That's probably the first thing that you notice, actually, is that you're getting annoyed by this repetitive reassurance seeking. Figure out how that is playing into their other relationships, figure out what's wrong. And so I think that it's not that you're pulling back from reassuring as much as you're addressing. It's not a balance with not being so reassuring. It's addressing why they're seeking reassurance so much. And that will make you less reassuring because you're not going to just keep answering questions for reassurance. You're going to wonder why this is happening. So it's like a diagnostic question, I think, even. Ilana.
I think we can see the demand a lot when we're working with people that are in marital strife, and they want you to validate the fact that their spouse is horrible, and you know that the clients themselves are extremely difficult, but they want you to kind of side with them and validate the fact that their complaints against their spouse are reasonable.
Right, so the comment is in marital situations, if you're treating one member of a couple and you're hearing a lot of complaints about the spouse, they want to be validated that their spouse is the one who's at fault. Or maybe a theoretical example where you're treating one member of a couple and your colleague is treating another member of the couple, and your colleague is pressuring you that you've read about this in academic journals, Lana, right? You've heard that happens, right? So, right. So you and the other therapists are taking different sides. So I do think that that's an illustration of the polarization that takes place in couples when each one is seeing a separate spouse, and it's one of the reasons that marital therapy is needed, and it has to be someone different than the individual therapist. It's also, I think, an opportunity for, therapeutic work that, it's just so important to you that I side against your husband with you, and I'm just wondering why that is. Like, if I don't, what are you worried, or what will it feel like to you if I listen neutrally, and if I would say to you, I don't know your husband's side of the story, what would that be like for you if I were to have that stance? But those are very difficult encounters, and also people in their marriages regress and feel really vulnerable and hurt. The people that you've made yourself vulnerable to are the people that can hurt you the most. So I think those are really charged clinical scenarios. So grievance-based identities, which, speaks to, I think, what you're talking about the trans community to some degree. That's a grievance-based identity. There have been people in various sessions talking about what they call a victim mindset. That's sort of like a lay term we hear now in our communities, where people just seem to be really insistent on feeling victimized over and over again. Those are situations where validation really is not going to be helpful. You will have done it for a while, but you'll sort of realize, wow, I've gotten into this pattern where someone, I'm like the one good guy in this evil world. And that is an easier role to be in, the one good guy, the only one that listens to them, the only one that understands them. I think that would be a sort of a common time that you catch yourself when you realize, wow, if his parents and all of his siblings and his neighbor and all of his children and his wife think he's being an obnoxious, toxic jerk, and I'm the only one that thinks he's nice, I'm probably missing something. I'm probably missing something. And we have all felt ourselves in that scenario. It's a very easy scenario to get in, because when you hear one person's side of the story repeatedly for a long time, that's the side of the story you hear. So we catch ourselves at some point in this. I think I don't believe any therapists have never had that happen. Moral certainty with patients when they're in like very ambiguous scenarios where there are a lot of ways to look at something, but they're so morally certain. I think that sometimes validation's, harmful there. And I'd say whenever the patient is soliciting the therapist to help avoiding knowing or acknowledging something. whenever that's your sense, that there's something that just can't be tolerated, and the validation would be colluding in avoiding that knowledge or that realization or that acknowledgement, that's when validation is probably counter-therapeutic, actually. In the back?
Have you felt that this pressure when patients come in, like a lot of adults with ADHD, and they've already been on the internet and they diagnose themselves and they go to support groups and they know they have ADHD or are neurotypical and being an experienced clinician, you assume there may very well be another diagnosis, but you lose the patient if they came in. If they sat down and that was your work has to be done for, before you could give that. What do you, and it could be any patient who come in and say, I self-diagnose as borderline or whatever. How do you deal with those?
Right. So diagnosis and self-diagnosis, and how the patient is going to experience either your disagreement with their self-diagnosis or your imposition of another diagnosis. I think that's a really good example. I have that example a lot, actually, because a lot of my work is like a second opinion diagnostic consultation. So it's, in a way, a little easier for me because I'm not going to be working with this person long term. I think that that is really a dilemma. If you're not the therapist, you have more leeway. Again, you're not dealing with the person. The other thing is there's sort of an art to using the diagnostic encounter with a lot of psychoeducation. And I think, I sort of work around it. I'm not really doing therapy at that point, but I'll say something like, well, here are a few different diagnoses that could explain your symptoms. I'm going to explain to you why some clinicians would say diagnosis 1, 2, or 3. And then I'm going to explain why I think it's diagnosis number 2, and I think diagnosis 1 or 3, is not a better explanation, and I will do that and explain why, and then I'll say, if I understand correctly, you told me you really don't want to find out that I think you have diagnosis number 2. I do think that that's the best explanation, and I'll tell you why, and also why it's important. I'd like to know why it bothers you so much. If the treatments that we give for this diagnosis would be the most helpful for you, do you really not want to try those treatments? And really, that's the most important thing about a diagnosis, is that it's going to indicate what might be the most helpful treatments. So that's sort of, I get very psychoeducational, spend a long time with it, acknowledge what the person doesn't want to hear, and that usually gets me out of trouble. Interestingly, the one area where it doesn't get me out of trouble is this rabbit hole that I promised not to go down, but I'm going to a little bit, which is when I diagnose autism spectrum disorders in people that self-identify as trans. That really will invalidate the trans diagnosis because it's going to be part of autism spectrum, and it's going to cause the gender-affirming care clinic to be less likely to recommend gender transition. And I have not found a way to make this work better, although often the parents are happy with my diagnosis, but the person, him or herself, is not. So yeah, it's a thorny issue. It's a thorny issue whenever identity politics are a big part of the patient's self-concept, because identity politics are very much about feeling validated and invalidated. It's more of a political issue to me than a clinical issue, but it has clinical implications. So we're going to transition now to empathy. And before we go to empathy, we're going to talk about compassion, which is related and distinct from empathy. So compassion, this is Webster's definition of compassion. It's the distress and suffering that is triggered by another person's pain and our accompanying motivation to relieve it. That's what compassion is. So, if you're aware someone is in pain, you find it difficult to tolerate their pain. Difficult to tolerate their pain. And you want to help end their pain. Webster's Dictionary. It's a lay term, okay? When something is a lay term and not a clinical term, it means the consensus is in dictionaries. It's not among therapists or the clinical literature. Okay, so this is just, compassion is a normal word. It's not a clinical concept. It's a normal word. It's not based on scientific research or systematic investigation by experts. This is a word that existed. It was recognized long before modern psychology or psychotherapy. It's not synonymous with empathy or altruism. It's not the same thing. By definition, it's a negative or unpleasant experience. And when I talk about this, a lot of people really seem surprised because people feel, I think, so motivated to try to help people who are suffering that they've actually turned that role, the role of being a caregiver, into a role that really is part of their identity. But compassion is pain with another person's pain. It is a negative experience. And the wish to end that pain is, it's a reactive emotion. That's what it is. I'm not criticizing it in any way. All of us, I'm sure, are motivated to go into this field because of compassion. I mean, why else would you want to go into a helping field? But it isn't the same thing as empathy. I'll give an example. My father, alav shalom, was a very, very compassionate man. With his clients as a lawyer, he was a very empathic man. But with me, if I was in trouble or I was suffering, he wanted that to stop. He did not want to hear about why. He did not want to hear about why his solution might not be a great solution. And he was a wise person, so his solutions were good ideas usually. He wanted me out of trouble, out of pain, and that's what he wanted to do. He did not want to hear about it. He didn't want to talk about it. He was not in an understanding, reflective position. He was in a let's get my son out of this trouble position. That's what he wanted to do. And that is a normal, good parent's observation. That's why a parent can't be a good therapist. You're all nodding, but you all try to do therapy with your kids. But, that's why we can't do it, because we want to stop their pain. We want them to be healthy. We want them to be happy yesterday, as soon as possible. So, someone raised a hand? Yeah.
The compassion sometimes may be painful, but it's less painful than my pain. I'd rather focus on your problems. That's why I go into therapy all day with people, so I can think about their problems instead of mine. So in a way, essentially it's not a positive feeling, but it can lead to relief from my own problems.
So the very interesting point is that people who have like a compassion compulsion, they may be avoiding their own distress or problems. It would be like an altruistic externalization of their problems, and I think that that's a very good point. I think that there's a lot of validity to that. Yes.
I think it's also why parents and therapists, like the therapist often think the parents are crazy, and the parents often think the therapist is really not, because they just can't look at it from the same angle.
The comment is that this explains why many parents and therapists think one another are crazy. I don't know if I quite get that. I can see how it would make the parents impatient because, they want this kid to get engaged already, or they want this.
Questions that are like, that's not what we need right now, or they'll make comments that, don't help their child, but it's just coming from such an emotional place instead of a logical one.
Right. Okay. So the comment is, again, more about parents and therapists. I think you were saying is parents and therapists have different goals. I think, what this really comes out to is that when parents are hiring the therapist to do therapy, the parents really have an idea about what an outcome would be that would show that the therapy is working. And the therapist can see other outcomes that would be healthier or as healthy. The therapist also realizes that, there's a lot to work out before this kid is going to be capable of doing what the parents have in mind. So this is just, I think, sort of, when the client is not the payer, and of course, all of us deal with this all the time because we have payers, we have multiple payers, benefactors, relatives, parents, third-party insurers, right?
I want to share an interesting scenario I had with a client, which I saw she's in a lot of pain. I suggested to go see a psychiatrist and take also medication. And she always refused, no. One of the sessions, she brought up your pain, touched me so much, I broke down crying. It really touched me. It was painful just to witness what she's going through. After that session, she went to the psychiatrist, take medication.
Okay, so the comment is that a patient who was refusing to go for a psychiatric consultation, that the therapist himself was so overwhelmed by her pain that he began crying, and then that motivated her to go. So that's an option. You can emotionally blackmail and bully your patients into getting, that's an option available to us. Okay, so, all right, so empathy. Talk about what empathy means. Empathy is the ability to accurately perceive another person's subjective experience. That's what empathy means, essentially. There are many different aspects of this, but they all sort of come down to this idea. Heinz Kohut is the person that was responsible for bringing empathy into the psychoanalytic literature, and he used the term vicarious introspection. That sounds, well, this is what good psychoanalysts do. They ruin their ideas with terrible terminology. It's a Masorah, old Masorah. So now, what he said also is that empathy in the clinical realm is based on systematic observation for, dozens or hundreds and hundreds of hours. And he saw this as a human capacity that needs to be cultivated. Everybody has the capacity for some empathy. Not everyone is born with equal capacity. Some people are very gifted in empathy. Some people are potentially gifted with empathy, but they have a lot of other agendas in their mind, which creates a lot of noise. Some people are just kind of like tone deaf for empathy, but they don't have no empathy. But it's in everybody, the ability to experience what someone else has experienced. And it's a subjective experience. The way Kohut talked about it with vicarious introspection, what he means is that I can imagine, vicarious means I can imagine being you, and I can imagine introspecting being you. If I see someone in the audience start to raise their hand and put it down, I can imagine they have something important to say, but they don't want to interrupt me. Or they have something important to say, and they're afraid of looking foolish. There are many hypotheses, but I can imagine doing that. The other thing is that I don't have to have experienced exactly what you've experienced in order to empathize. Empathy means you can go beyond your experience and vicariously, accurately imagine another person's experience. It's based on self-knowledge. It's based on your own insight. It's not based on having traveled abroad and spoken different languages and having been both genders or having been in multiple cultures. It's not based on that. It's based on knowing yourself really well and imagining yourself in another culture. Now, the more you know another person, yes, your empathy will be deepened. The more you know, the more you understand another culture, your empathy will be sharpened because you will realize, they're coping with a totally different problem than I was aware of. I remember the first time in a Hasidic community, I will get to your question, I promise. The first time I was in a Hasidic community and saw a dilemma where the oldest sibling was suffering from pretty severe mental illness, and the family had to marry off a younger child before the older child, I just didn't understand I just thought this was the craziest dilemma. The oldest child is so severely ill, could not possibly be married, and it was going to be such a disgrace for the family. I just didn't understand the culture. So I was off in my understanding of the parent's dilemma, but it's not because of a lack of empathy. It was because of a lack of cultural competency. That's what I didn't. It's not that I lacked empathy. It's that I didn't understand. I have the capacity for empathy. I just didn't understand what they're coping with in some way. So there are things that can interfere with empathy. Very smart, bright, quick people who will eventually make wonderful therapists actually start off as really clumsy therapists because they can't really pace themselves, and they misunderstand people all the time because they're imagining everyone else thinks the way they do. And they have to learn that their minds are unusual. So a lot of very bright people need a different kind of supervision than people who are sort of like more attuned. They can become very attuned and very, gifted ultimately, but there's noise in the way. We see that with supervisees. People have their things, their pet interests, their projects. So agendas can interfere, but it doesn't mean the person lacks the capacity for empathy. It means that there's something else, other noise interfering. Yes, in the second row, you had your hand up. Yep.
I'm curious if empathy, because we're saying it's the ability to accurately perceive another person's experience. So isn't it kind of like based off the other person experiencing it? Like we might think we're being empathetic, but really it's based on the client and patient's perception of how we're understanding it. Am I making sense?
I think that the comment is, wouldn't empathy be the communication of something that resonates with the client?
Yes.
Okay. So as opposed to, so again, this is an issue of semantics. What I'll say for these purposes is empathy describes the therapist's capacity to understand. Whether you choose to communicate that is actually a matter of clinical judgment. And it isn't a matter of clinical judgment? Go ahead.
What you're saying is right, but that's not what I guess I don't understand when you reworded it. I'm saying, like, let's say someone's my client and I think I'm being empathetic, but they don't think that because I'm not necessarily acting.
Oh, in other words, the proof is in the pudding that if you're, okay, so we will not ultimately know if we are accurate in an empathic hypothesis until it's tested with what happens with the patient. That's sort of true. But I'm now still talking about the capacity for empathy in general. The capacity for empathy. Was this actually an empathic intervention? When I said this, I'm imagining that you feel in such and such a way. Was that there's a lot of dimensions to that. First of all, was it a useful, helpful intervention? Did the patient experience it as empathic? There are many levels to that. I think you're right that to some degree the patient's response, but sometimes we will be aware of something that the patient doesn't want to be aware of, and they may experience this as jarring and upsetting, and whether they're going to disagree and deflect or it's going to make them more open depends more on the patient's openness and about your relationship with them, but it still might have been correct. So, what's helpful to say is somewhat of a different question than whether you're empathic. People are pretty good at imagining what someone else is going to do. They really are. The times when it's hard is when you have a lot of your emotional stuff going on at the same time. But people are remarkably astute at imagining what other people are thinking. They really are. Was there a comment over here in the back?
So I have a question. It might be wading into a little bit of diagnostic territory, but if I am a clinician and am observing that my client is having a lot of trouble being empathetic, right? So sometimes I need to have
The client is having problems with empathy, did you say?
not me, but for other people in their life,
Right.
or respecting a certain situation. So sometimes it has to do with personality disorder. Is there another explanation?
So the question is, if someone has a problem with empathy, it might have to do with a personality disorder. Is there another explanation? So I would say that if someone routinely has trouble empathizing with others, they're very likely to have a personality disorder, regardless of the cause of that, because I think that empathy is a really important tool in all relationships. So if someone is routinely erring in their sense of other people, then they're going to have problems in relationships. And if people have pervasive problems in relationships that causes, subjective distress and social and academic or occupational problems in their lives, that's already one of 4 criteria you only need 2 of to have a personality disorder. So lacking empathy does cause people a lot of relationship problems. But I would also say that there are scenarios, anyone that's overwhelmed is not going to be empathic because they're overwhelmed and they don't have the mental space right now to think of other people. So while someone's in a depressive episode, they're less empathic. While someone is suffering from OCD and plagued with obsessions and trying to carry out compulsions to rid themselves, they're not thinking about other people. When people are angry, when people feel hurt, when people feel injured, when people are symptomatic from PTSD, when there are many clinical problems that make you not at your best, and empathy is a feature of people while they're at their best. So, I think any impairment in functioning, it's a really good question. I've never thought of it this way. I think anything that causes an impairment in functioning, that, you're going to be doing worse in all the domains of your life, your empathy will also suffer in those moments. There is another field of study in it's an interdisciplinary field at this point, mentalization. So mentalization is a precursor for empathy. It's not the same thing. It's the ability to not even the ability, the tendency to think of other people's motivations when they do things. So if someone would come in the room and do something very, very strange, and it disrupts the lecture, if I couldn't mentalize, I would just think that person hates me and is trying to humiliate me and ruin my lecture. Because I feel embarrassed, I will attribute my feeling to that person. That's a non-mentalizing. Hopefully I'm in a better mood than that today, and I would say, wow, is this person psychotic? Is this person scared? Is there a fire? I will wonder, why is this person doing something that's so socially inappropriate? And I will wonder. That's a normal response. That's how most people, that's about 2/3 of the population will wonder what someone's motivations are for something they did wrong. They might not be right. You don't have to be right, but you'll construct a reasonable hypothesis automatically. You don't do that. You don't try to do this. This is just automatic human behavior. That's how most people operate. There are disorders that are non-mentalizing disorders where people don't mentalize normally, and those people will really have a lot of trouble with empathy because they don't think of other people's motivations in general. Yes? The comment is people with developmental issues would also be impaired in their mentalization and their empathy. Yes, and people on the autism spectrum can have a lot of problems with empathy. They're not noticing people. They're not, they don't get social cues. Their radar, they have interesting radar. They can detect things that no one else can see, and they're not interested in the things that all of us are afraid to bump into. So I think you're right. And a lot of us experience people who are on the autistic spectrum as not understanding that we need to get out of this conversation, that they're talking too loud, just a vignette. I have a patient right now in treatment, an adolescent girl with autism who autism spectrum could be called Asperger's in the previous classification. I really adore working with her. I just love this girl. And she comes into my office. She sits on the analytic couch rather than the other chair, probably because it's closer to me and she can make me more uncomfortable. Then she pulls the pillows out of the way and leans all the way over and talks to me with her nose about to hit my nose. This is how she talks to me. And she said to me, "So, you really think you can understand me, Dr. Klafter? Do you know what it's like to have menstrual cramps? I have my period. I have menstrual cramps today. Tell me what I'm feeling if you're so understanding, Dr. Klafter." This is what she says to me. So, and this is, but she's toying with the idea of empathy. She's actually trying to wrap her head around it, and she's constantly accused of not understanding people. That's her difficulty in life.
Say no
I could. That's not what I chose to do because I didn't have you as a supervisor. That's not how I chose to handle it. I chose to explain why, yes, I think I can, why I think I can understand this. Yes.
It's very similar to addiction also, because the person that's acting out in addiction is not thinking about how he's affecting the other person. And then when he gets found out, he has a hard time, he or she has a hard time showing empathy for the other person that's been hurt.
So the comment is about addictions and about how in the throes of the craving, intoxication cycle, before recovery, and probably for a long time during recovery, people have been oblivious to the impact of their behavior and their addictions on their loved ones. And that's, I think, why inventory and amends in the 12-step model are such a long, deep endeavor in order to make those repairs. It's also interesting, so I had two of my two favorite supervisors were always fighting with one another at Jefferson Medical College, and they wrote a paper about addictions and personality disorders, and they disagreed with one another. One wanted to coin the phrase apparent personality disorder. The other felt that the personality pathology that you see during addictions is just a magnified version of the psychopathology in the person's personality to begin with, and that's what their debate was about. I actually think that the former was correct. I think that there are people that can really look like they have a full-blown personality disorder while they're in the midst of an addiction, and depending on how long the addiction has gone on, they may really be very arrested in their development, because if people are addicted for 10 years, they're just not maturing that entire 10 years. Like, they're not paying attention to other people, they're not working, they're not responding. Like, so it's like development has been frozen. But some of those people, when they are sober, can really do very well with treatment. So I think that one of the supervisors was right, the other one had it wrong. I thought it was sort of a bias in not understanding the deep impact of addictions. So back to this. So it's based on self-knowledge. So it means that you can, without being a teenage girl, understand. Now, I raised 4 teenage girls, and I've had physical pain in my body. I've had surgery before. I think that we can transcend the limits of our experience, and we can see some experiences that we've had and imagine them extending into other areas of our life, other areas of our bodies. I think that those of us who have not faced aging yet can understand aging. I think that those of us who have never been a man can understand what it's like to be very insecure about one's manhood. I think that those of us who have never been a woman can understand things that women experience. I do believe that, and I think that's what it means if you believe in empathy. I can understand my Latina lesbian patient who was abandoned in childhood, even though, which do you guys think I'm not Latina or not female? Which one do you want to go for? So, and I wasn't abandoned in childhood, but I do believe that I can understand that. This is something that, again, with identity politics, this is challenged by identity politics. There was a movement to try to match patients with demographically matched clinicians. I'm not against that, whatever makes someone more comfortable, but I do believe that empathy transcends all these limitations. I think that we can empathize with animals. I think we can empathize with animals. Menachem, I'm deciding whether to call on you because I know you're going to argue and it's going to sound very effective, but I'm going to call on you anyway. Oh, okay.
Is listening, so when your client says, can you understand that I'm having menstrual cramps, do you already at that point have empathy for her, or is it necessary for you to listen to her, share her experience of menstrual cramps in order for you to develop empathy for her experience?
Perfect question. So what I think is that Yeah, I can repeat. The question is, when my patient challenges me about whether I can possibly understand her experience of menstrual cramps, do I already feel that I have empathy for menstrual cramps? Do I need to kind of enter an imaginative mode to cultivate that and call it to mind? Or I'm not sure if you said this, but I think it's implicit in your question, over time as I get to know her better, will I develop empathy for her menstrual cramps? What I think in that moment, I'm going to answer your question also, but the more immediate answer to your question is I am empathizing with her need to challenge whether I can understand her. And I think that's the relevant clinical moment, and it's not about menstrual cramps. I think it's about how much she's going to open herself up to me. She has been ridiculed and humiliated by all of her colleagues. I think that she really likes me and likes seeing me. I think that that's scary on some level. Her parents have started to trust me, and they're very untrusting parents. I think that's scary on some level. And I think that she's starting to feel very close to me. She's getting very curious about me. She's usually not curious about people. She's finding out about my family. She has no concept of boundaries, and she's in our community, so she learns about me. There's many people she can ask about, gossip about me. So I think actually what I'm empathizing with is her fear that she's letting herself open up to someone who's going to hurt her. So the actual intervention is, well, no, I think I can understand that, and I'll explain why I think I can, but what is it? Why do you want to make sure? What's going on today that you're worried that I think I understand you and actually I'm going to misunderstand you? I think that's the more empathic that's what I'm empathizing with. I don't think that menstrual cramps is actually the issue. Now, if I were seeing someone with endometriosis and is really suffering from pain all the time and it's interfering with her functioning in life and she has infertility problems and it's really about her reproductive physiology, then that would be sort of like a different clinical sense. But in this situation, I think that's the empathic moment. Now, in general, I think you're right that we don't necessarily, we will have an empathic experience that bubbles up inside of us. It's not like a deliberate thing that you're thinking about intellectually. So it could be that someone will say something to you and you really weren't thinking of that before. You weren't thinking that before. It wasn't on your radar. Now that it's on your radar, it will take some time to really understand what's going on, and that might take weeks or months or years in some cases. But that is, it's a more naturalistic, I think, phenomenon. You can't sort of access it deliberately. Yitzi.
So I have it's a two-part comment, but I think what you're saying is that you might not know the biological experience, but that's not what that doesn't matter because you're talking about everything. And by extension, at Nefesh, the question of room therapists will be solely from patients, and the question of what's empathy and what's identification. In other words, how much of am I knowing what your experience is simply because I have a similar experience? How much that we water down the question of what is actual understanding of what the patient's trying to tell you?
Okay, so there was a comment and then a comment, but it is a question, I think, the second one. So the first part is that empathy is not about having experienced the same biological phenomenon. It's about being able to imagine someone else experiencing it, and I totally agree with that. The second is the difference between empathy and identification. So that is, that could be a talk that you should give next year at Nefesh. There is a paper that was written, I think, in 1980 in the American Journal of Psychiatry, and it's called Shared Cultural Scotoma. Does anyone know what a scotoma is? A blind spot. Yeah, it's an ophthalmology term. It's a blind spot. So this paper was in response to the movement in the 70s of matching people with demographically similar clients. And the allegation of the paper was that it's true, there are some things that by virtue of being in the same community, you're going to understand more quickly than people not in the community. But his experience with his supervisees in the clinic is that there are blind spots in every culture, and that if you are over-identified through demographic similarities, you deny the patient the opportunity to have someone wonder about some of their cultural assumptions. And so I think that that's related to what you're talking about, that when you share an ethnic background with someone, you share assumptions, and not all assumptions are best shared. It's really helpful to question some assumptions, and it's harder to question the assumptions that are like the sacred cows, to mix metaphors, of your culture, because they're your sacred cows also, so it can really interfere. And that would be a barrier to empathy or a barrier to understanding. I know that there are many patients from Orthodox homes, or who are Orthodox themselves, who will say that really these experiences with non-Orthodox therapists who did not understand me or my culture, it was just such a headache, and it was so much time explaining things, and I just don't want to bother doing that again. But a lot of other people say, I'm so glad that I saw someone outside of my community. I had the opportunity to talk about things, to explain things, and I really grew in ways I think I wouldn't have with someone that was from my community. So I think there are pros and cons. I usually just think good therapy is going to work, and it doesn't matter that much, but that was at least the observation of one author. It's an interesting paper, Shared Sculptural. If you can't get it, email me, because I have it to give out to residents in the clinic in the back.
I'm just saying, just even on a more fundamental level, aside from blind spots, when you're in therapy with someone who demographically seems similar to you, there's always the danger of the assumption that their experience of whatever it is, marriage, child raising, having older children, is going to be more similar to you. In fact, the challenge to remove yourself, more of a challenge, remove yourself from the experience and leave space to hear what that patient's experiences actually are, because they can be radically different from you, or even if they just broke down the lot with children.
Right, so interesting comment, which is that if you share the person's ethnic or cultural background, it can give you like a sense of arrogance that you understand everything about them because you're the same. And in a weird way, you will be painting with a very broad brush, even though you should know differently because you're in that community. And it reminds me of a friend who has come up with two terms that are really funny. One of them I should have used before. He calls it compassion pornography, which is when people are so into being compassionate and love to tell stories about their compassion and how compassion is healing. Like it's sort of like a motif now, compassion. And then the other was cultural competence narcissism, which is, there are therapists that's like, oh, I know all about this. You don't have to explain to me. I know exactly what this is like, which is, such a crazy thing because every family is so different about so many things. So I think those are astute comments. I'm going to move on a little bit. So I was saying this, it's not limited. The belief in this, you can disagree with this. You can disagree with this, but you should know you're disagreeing with the concept of empathy to some degree. It's not limited by gender, race, age, or culture. And the other concept from Kohut, which is a little bit abstract and intellectual, but it's interesting and important, is that every concept in psychotherapy, no matter what modality, was developed through empathic listening by therapists. Like every concept we have was developed through the therapist's empathy. So anything you come up with, a distorted automatic thought, the only reason we came up with that concept was tens of thousands of hours of clinicians looking at what was going on with their patients, talking about it with one another at conferences, or writing about it, and it was all based on empathic knowledge. The data for psychotherapy concepts is empathic knowledge of what's going on with the client. So it's not just the empathic moment in therapy that is therapeutic in some way. It's all the data we have for psychotherapy. That's how psychotherapy, like the science of psychotherapy, is based on our empathic knowledge of patients. So to some degree, that's like daunting because like, well, how do we know that we're right? But because empathy is so essential and ubiquitous in humankind, it's sort of like saying, how do you know that the sense of smell is right? How do you know that the sense of taste is right? Like maybe chocolate doesn't taste good. Maybe, the entire population except for my third daughter is wrong, and maybe chocolate is horrible. My third daughter hates the taste of chocolate. We don't know whose child she is, but whatever that is. But, there are certain things. So empathy is like that clear to people. Like there are many subjective things that everyone accepts as valid. Like, is love real? You have all had patients wondering if love is real, right? People have wondered this. But love is real. I mean, we know love is real. How many people are murdered in the name of love? If it weren't real, there wouldn't be love. So that's, I think, how to see empathy. It's just like that part of being human. That's how embedded it is in being human. So some common misconceptions. I think we've probably talked about most of this. Compassion is a common motivation for therapists and helping professionals. We don't feel it equally for all people. Okay, that is something that just is true. If that hurts your feelings, I'm sorry, but please make an appointment to talk about this. The pain you feel when your children are hurt is different than when my children are hurt. It just is. And I do take that personally because that hurts me also. But, we are more reactive about some people's pain than other people's pain. That's just a fact. It must be overcome in order to cultivate empathy. This is a weird thing, and I'm not saying compassion is bad, okay? Compassion, I would never want to see a therapist with no compassion. Never want to do it. But I don't want my therapist to be like my dad. I absolutely adored my dad. I miss him. I talk about him all the time. But he wouldn't have been a good therapist for me. He wouldn't. He wouldn't have been a good lawyer for me either, because he was a good lawyer, but he probably wouldn't have been my good lawyer. So you have to overcome your compassion to some degree to be able to stick with helping your client. Many compassionate people have tried to help our clients, and they've given them very good advice. And they haven't been able to take the advice. So you don't have better compassion or better advice than all the other people in their life. You really don't. You have to help them work on what interferes with their following good advice, and that's their personality pathology, their distorted thoughts, their defense mechanisms, their arrogance, their narcissism, their inhibitions, their all the problems that they have that are stopping them from doing. That's what you have to work with. It's not that your advice is going to be better. The inability to tolerate your patient's pain would interfere with your ability to help them with it, because the fact that you can't tolerate it is not going to make the pain go away. It really isn't. So you have to learn to sit with pain, and it can be very hard to do. There will be certain patients that you react to more than others, and that's your compassion. It's not something to feel bad about, I would rather be guilty of being too moved by my patient's pain than guilty of being cold to their pain. But to be a good therapist, you have to be able to tolerate that pain, because it's not going to go away anytime soon in certain cases. Empathy requires sitting with those feelings, not succumbing to the urge to end it. There's a saying, don't just do something, sit there. That's like a famous psychotherapy supervision saying, and this is what it means. Yes?
Would you say that a parent actually, instead of cultivating their empathy, should cultivate their compassion, essentially, while the therapist, on the other hand, cultivating their empathy? And then maybe we say co-hug, we do self-psychology. It's no coincidence, this precarious distraction piece, as opposed to the analysts prior to that who viewed some of their work as reparenting.
Okay, so I'm going to have to stop you now because you've given the thesis for 9 different talks at Nefesh and that very deceptively simple statement. So the comment was a few comments combined together. Number 1 was, do parents need to cultivate compassion and therapists need to cultivate empathy? And then there was a statement about how Kohut introduced self-psychology, which makes sense because a lot of the therapists or analysts that came before him believed in a concept of reparenting, and Kohut was bringing in something different. So let's get to the first part of that first. I think that it's very hard to generalize what parents need to cultivate because there are very different parents and they have very different kinds of challenges and problems. So there are some parents who are not very compassionate. Most of the parents that we meet are very compassionate, and depending on their level of anxiety or distress, or whether it's a family with a lot of multi-generational Holocaust trauma, or whatever might be happening, they are overwhelmed by their kids' psychological problems. And then we meet some parents that are just amazingly wise, and they get it, and they say, my child needs a therapist. I've tried to give the advice I can. My advice is offending my daughter. I'm hurting her feelings with my advice. I don't know why it hurts her feelings. I guess she thinks I'm calling her stupid, that she needs advice, so I think I have to pull back and stop doing that, but maybe you can help her. I'm going to stop giving advice unless she comes to me for advice. I think we see all kinds of variations of the parent, so I don't generalize what parents need. I do think that compassion is like the normal parental experience, and empathy has to be kind of the normative therapy experience, if that's what you mean. But some parents really need help in different kinds of skills and directions. Now, as far as psychoanalytic history, I don't know that I agree that reparenting was the dominant or even a dominant analytic model. There was one group of therapists. It was centered around Franz Alexander and Thomas French, both in Chicago, and they believed in something called the corrective emotional experience. The corrective emotional experience was the idea that what you missed in your childhood, let's say you had a very permissive home that was a Hefgewelt, and it made you anxious and overstimulated. What you really need is you need an experience with an authority figure who's going to give you a lot of structure, a lot of caution, a lot of advice, and that's going to fill in what you missed in your childhood. Or the reverse, you had such a rigid, controlling home, you really need someone that's going to have more confidence in you, let you figure out who you are, and this is going to compensate for that. That was Franz Alexander's corrective emotional experience. Thomas French, his friend and colleague, had a notion that was, what I need to do is I need to anticipate the kind of parent that you missed out on, and then I need to posture myself as that kind of parent so you will have a transference to the kind of parenting that you missed out on. It was an impossible task. It didn't catch on. It was actually rejected by the psychoanalytic mainstream. In analysis, if you would accuse someone of operating a corrective emotional experience, that was a tremendous put down. That was like being called a kaifer, or being called, that was really not acceptable. And Heinz Kohut was accused of being like a Gilgul of the corrective emotional experience, and that's why he had a lot of trouble with the psychoanalytic mainstream. So I have a different view of the psychoanalytic history of that. We'll move on. So we're going to take empathy a little bit deeper now, since Kohut. So complementary to discordant empathy, this is the idea. So there is a wonderful author named Stefano Bolognini, and he talked about 2 kinds of empathy: concordant empathy and complementary empathy. Now, this isn't compliment with an I, like where you praise someone. It's compliment, meaning like filling in what is missing, like a companion, a complement, an additional thing. I'm going to change the term to discordant empathy, concordant and discordant. Concordant empathy is where I empathize with what you are consciously experiencing. So if I think of an example, it's very close to validation is actually what it is. If I say to you, oh, I see that you really want to be called on, I'll get to you in a second, okay? That's concordant empathy. You're aware she's joking around with me about it. This isn't a real thing. She's raising her hand up and down because I said that. You were, when you were teasing me with this, right. So if I would say that, I see you want to be called on, I'll get to you in a second. That's not very deep, and I am noting what you're aware of. You're not aware that I'm aware. I'm registering that I know this. If I would say, and I don't really believe this about her, don't worry, but I would say, I think you're annoyed at me, and you think that you're going to be okay, but you're not, right? So if I would say, I think that you really have a problem with what I'm saying, and you are eager to correct me, but you're afraid I'm going to get mad at you, that would be, no, I don't really believe that, actually, but that would be a hypothesis about something that you're not aware of. If I were correct about that, then I would be empathizing with what is unconscious in you and what you are disavowing and don't want to believe about yourself. So that's what he calls the complementary empathy. So the empathy that's actually helpful is typically the aspects of your mental experience that you are unaware of. And so the notion is that you can experience things that the patient is experiencing unconsciously and not consciously. And that's often, when we talk about empathic interventions, that's really what we mean in depth psychology. We're talking about what someone isn't aware and doesn't want to be aware of and would be very upsetting for them to acknowledge. So the first thing that we're going to talk about how we get to this in our work, but ultimately that's a very different kind of experience. And when I say the complementary empathy, it feels jarring. Okay, this feels very jarring. I see my pieces are going to come out of order, so I'm just going to do this. It's jarring. The therapist feels or experiences what the patient does not yet know, thoughts, what feelings and thoughts. It's structurally non-validating. Okay, it's structurally non-validating because this is what the person would not agree to consciously. So I want to call this discordant empathy. It produces discord. It produces distress. It's similar in cognitive. Who here is trained in cognitive psychology, cognitive therapy? It's going to be similar to the cognitive corollary of this would be cognitive dissonance. Okay, cognitive dissonance would be like but you'd be looking at the same stuff. I don't talk about it as cognitions. I think it's emotional, and I think the cognitions are sort of a derivative of the emotions. Yes? That feels very validating. Okay, so one day we'll have an arm wrestling match with slides over which view is better, but this view would say that ultimately the thoughts are derivatives of the emotions, and the emotions are not derivative of the cognitions. That would be the difference, but we'd be looking at very similar phenomena in the consulting room or in someone's life. We'd be looking at very similar stuff. I'm going to get to Menachem in a moment. So the question is, what is the source of that information? I mean, how do you know something? How do you become aware of something? How do you feel something that the patient is feeling but unconsciously? It just sounds like, it sounds like magic. It is not magic, but it sounds like magic. Yes, Menachem. So it's a really important question. So could what we're calling, I think this is what you mean, discordant empathy, we'll put quotes around it, like what you want to allege is discordant empathy, could that actually be your fantasy and it's what you want the patient to be feeling? Absolutely. But let's for the moment not worry about that, because that's that would be, an empathic failure or an error. But yes, certainly therapists make empathic errors, and it's based on their biases or their wishes or what they can't tolerate. Usually, if you have a fantasy that is inaccurate about what a patient will be feeling, that is probably coming from something you can't tolerate, and it's going to be sort of an undoing of what you wish weren't the case. I'm going to go to Frady first because you just said something.
So I love that Yaz is a term for something that I'm using all the time, because I think it's particularly a clinical term for something that I do a lot with my clients.
Discordant empathy or empathic errors? Which one?
But so I'm really appreciating that, because now I'm understanding for myself what I'm doing, so thank you. You can send me a bill tomorrow, I'll check for that. But it's interesting because I've noticed, and now that I'm sitting here with it, I'm noticing within myself that when I approach my client with understanding of their subconscious or whatever, what's going on for them, I notice that I'm always giving like a precursor or like a little disclaimer, like I'm always, because of the clients that I work with, complex trauma and such, I guess I'm afraid, and I'm noticing this within me, that I'm afraid to just say it, what I'm experiencing, that they might be.
Okay, so I'm going to summarize your comment now. You have the last point of it? Go ahead.
No, that's it. I'm just saying, I'm wondering
Right.
if that's something that you find as well, that like there's this uncomfortability or fear, how it's going to land for them.
Okay, so comment is, really in response to Menachem's comment about it could be an error, it could be your fantasy. So
No, not a fantasy. It's not a fantasy. I'm not saying that.
that you might be wrong, that you might be imposing.
Not that it's going to be wrong with that imposing. No, I'm not worried about that. It's more so how they're going to take it due to their highly traumatized state.
Oh, okay. So even if you were, had a verification that this is correct, what will it be like for someone to experience this? So, okay, so that leads to, again, the question of when saying something is helpful. So I believe that this was the Alter of Slobodka, who was quoted by Rabbi Yaakov Kamenetsky, who said, but someone can correct me if I have the lineage wrong, that not everything you think should you say, not everything you say should you say publicly, not everything you say publicly should you write down, and not everything you write down should you publish. And then Rabbi Yaakov added, and just because you published it doesn't mean it was good. That was so that really does apply to psychotherapy. We have all kinds of thoughts and all kinds of feelings in therapy, and they're not all therapeutic. Some of them are daydreaming, some of them are, and so how and when to say something is a matter of, people call it timing, but timing is sort of a tautology. Like there are situations when this would be helpful to say. There are situations when this is missing what the patient wants to talk about. Like I'm having a realization, this often happens to me, I'm having a realization of what the patient really was talking about or what they really meant 2 weeks ago. It's like, oh, I get it now. I was so oblivious 2 weeks ago. But the patient has something pressing that they're talking about now. So like if I'm going to talk about what was amazing 2 weeks ago, then that's going to be really off. Sometimes you'll say, I'm just realizing something that I just want to put a pin in it for a later discussion. You said something 2 weeks ago about your dad. I want to get back to that the next time you come. I'm just marking it now for next week. Please continue with what you're saying. Or sometimes you'll just file it away by yourself. It's not always relevant to what they're talking about. Sometimes your sense as to what the patient is, not wanting to acknowledge. Now, when I say defending against, it sounds very intellectualized. Let's be very practical. You're really, really disappointed in this shidduch, and you're really, really upset that your parents picked him for you, and you have really strong doubts about this marriage going through. That could be very difficult or impossible for some of our patients to say to themselves, but we believe that it's true. So what are you going to do with that realization that you have? You could be very, very confident it's true, and whether and when it's helpful to say is not something you can give general rules about. It depends on so many factors with what's going on with that family, with that patient, with you in the therapy. How long do you know them? Are they going to even listen to you? Do they trust you? What will be done with the information? If the person doesn't know it, that's going to be a whole therapy just to get them to be able to realize this. Then what can they do to act on it? And by things happen quickly in some of these engagements, and they may be married by then. So there are a lot of situations where you have a realization about something. It's your hypothesis, your conjecture. It might be your fantasy. But sometimes there's a lot of information that really makes it look that way. It really seems quite evident. So when you're going to say something is like a matter of technique that we get better at all the time. We consult people for supervision. That's a different question about when to say something. I will also say that I often say to people, I have something that I'm imagining. I'm not sure it's true. Please listen with a grain of salt and tell me whether I'm right or not. So, yeah, so I do that all the time, and I do think that.
But it's not that you're scared, you're right, you should be cautious. And she made it sound like it's her problem.
Well, she's working with a population where it could really be harmful. She's working with people that are, so she is also afraid of committing harm because people can, this is a very sensitive, delicate population that she's working with where there is more of a risk of iatrogenic harm from the therapy. But even in a case where I don't think it's harmful, I find that helping patients understand how I've come to an empathic hypothesis, even if it might just be my fantasy, like Menachem was saying, if I say, I don't know if this is my idea or your idea. I feel like this is your idea that I'm picking up on, but if you think it's only my idea, please tell me. I find that patients learn a lot when you share how you got to your thought, and I think that it gives them confidence to get to their own thoughts. I just think it's part of the therapy. People think the therapy is the content of what you say, but sharing how you know something is so therapeutic for patients. So I just find that that's a very helpful thing to do. I also find that it makes a spoonful of uncertainty helps the medicine go down, I guess. So I find that that's helpful for people to listen. They don't feel pressure. And I actually don't feel like I'm not going to be upset if I'm wrong or they disagree with me. I'd rather have the freedom to say something that's not true. There's another paper, I think it's called The Therapeutic Benefit of Inexact Interpretation. That's what it's called. It is very frequent that you will say something, you'll say, this is what I'm imagining, please tell me if I'm wrong. And they'll say, oh, no, that is wrong, but now that I see what you're thinking, I realize this is actually what I'm feeling. But you had to model something wrong before they would know what they're feeling. That happens all the time. And that's actually probably a better intervention than being right. And I'm not deliberately wrong. That's probably a better. So you're inviting them to refine everything happening with you. So that's a better collaboration for therapy. So that's most of my interpretations are preceded by something like that. Yes.
You basically answered most of my question, but.
Oh, does that mean we can go on? No. Go ahead. Right. Is there a benefit in withholding something to let them come to it on its own? Probably, but I don't think I have the self-control to do that. But it's hard to, there are going to be many opportunities to get to something on your own. If you really believe that someone will get to something on their own and you saying it won't be helpful, then yeah, in theory that would be the case. But usually I think I'm going to be somewhat off and they're going to refine it with me. And it's sort of it's really not that different than working on a presentation together. You bang something out on the slide, your partner says, that's not quite right, let's do this. Or you say, oh, that makes me think of this. It's sort of like that usually. So I don't know that there are certainly things to not say. but usually withholding your best insights is not helpful. People usually like to hear what you think. They find it helpful. If you're like, just obsessed with your own chidushim, that's not going to be helpful, but I'm not talking about that. Usually patients appreciate your best effort to try to clarify something, even when it's wrong. And I haven't had people mad at me all that much when I'm wrong. A few people, but they have a need to get mad all the time, and that's like a separate issue. So, now calling it discordant empathy, like I'm using that name because that's what it feels like to someone when you say this. So I think this might be a good time for a 10-minute break, but you have to be here. Don't take a longer break than that, please, and you can stay here if you want to, but some people I think would need a bathroom break or want to stretch their legs. But okay, so we're going to start to get to countertransference as the starting point for empathy, and just as a preview. So this is a patient that says, and I haven't met anyone interesting in years. And the analyst is thinking, what am I, chopped liver? So this cartoon captures a lot, actually. And so we will, in 9 minutes now, we will start to talk about how countertransference is the entry point, usually into learning what's deeply happening inside the patient. So I'm going to call this countertransference as the starting point for empathy. And again, how do we know things that patients are feeling, but they don't know that they're feeling them? How do we experience things that they're not aware they're experiencing? So I will be reviewing the ideas of transference and countertransference, but I think it will be in a new way that I hope will make these ideas more practical and more related to empathy and how we access these realms of knowledge about our patients. So transference is the characteristic ways that we relate to others. That's what transference is. It is how I imagine you feel about me. That would be my transference to you. How I imagine you will respond to me, that's part of transference. How I feel about myself is related to how I imagine you feel about me. It's a permanent part of our personalities. So the transference, if you're calling it transference, okay, it means that this is going around with you all the time. It's not just because I have a certain feature of my personality and I stimulate you in a way that no one else does, and that it's about me. It's the part of you that's always with you. You had this in you before you met me. You carry it, that's a typo, you carry it with you everywhere. We carry it with us everywhere we go. There are specific situations and personality types that trigger different reactions. Like if people feel criticized and in trouble and mad at them all the time. Someone came up to me and was talking about people-pleasing. So people that are constantly entering like a pleasing posture are people that are afraid of being in trouble and people being mad at them all the time. So someone who's very authoritarian or reactive or has a temper will probably make them feel even more people-pleasing. It will be exaggerated. But it was part of them everywhere they went. It's mostly influenced by early childhood experiences. Let's do a thought exercise together. Who will share with us your absolute first memory that you're aware of? What is the earliest memory that you're aware of? My first memory is I remember being in my big sister's lap, who's 7 years older than I am, in our front lawn, and my mother was playing with me while my sister was holding my hands and playing with my mother. That's my first memory that I have. Someone in the back is going to share a less pleasant one, I'm guessing. Oh, I don't know if you're raising your hand or just adjusting your yarmulke. Oh, Yitzi, were you sharing?
I was going to share one. I remember standing on a chair at my upstairs, and this big birthday cake in front of me, and my mother and grandmother having an argument about it. There's no video of it.
Yes.
Just to talk about the impact of traumas, my earliest memory, as you said, I think I was 2 years old, was me getting stitches. I remember like being under the lights and
Getting stitches.
the nurse.
Yeah.
So I guess the trauma impact.
Okay.
I remember my mother and grandmother talking about babies, and I'm thinking, who's the baby?
Remember, I was at Toys R Us with my mother. I was supposed to buy my first little big wheel. And she's looking at the big wheel, and I said, no, I don't want a big wheel. I want the inchworm. And she goes, but it goes so slow. And I ran up to her and I kissed her on the nose. My inchworm.
Okay, we'll do a couple more. Mark.
I remember, there was a time when you had these wooden cribs that sat on the floor. And I remember the slats of the wooden crib. I remember kind of like just barely, I don't know standing, but I was like hanging out in the crib, watching things happen. And I had like a little stuffed animal. But I remember the wood.
Okay. Yisrael.
Eating dishes with my grandfather. That was, people also always understand.
So we won't go into it here, but probably, well, we can see that many of these first memories have a narrative to them. There's relationships in the family. There's people arguing, people playing. My memory, which sounds really lovely, but the truth is that my sister was from my father's first marriage and adopted. His first wife died, and she was 6 when my father married my mom, and my mother adopted her, and they had a lot of difficulties over the years. So a lot of my treatment was about discord in the family and feeling the responsibility to repair it and feeling the pain of other people being mad at each other. And that was something that was a recurrent theme throughout my life. And I seemed to always be in scenarios where there were a bunch of women around me fighting with each other, and I was very sensitive to it. And so a lot of our first memories, so the first memory is... one comment was made, like the influence of trauma, but just the first memories capture with them lots of embedded narrative that can be very meaningful. And I imagine a lot of you that, have had therapy, that those first memories, if you think about them, they capture lots of things. And so why is this relevant to transference? Because the ways we feel about ourselves and what we imagine about other people, these are old parts of who we are. They get modified and they get layered on top of later, but these are our old, primitive, powerful parts of who we are from when we were children. And so when we talk about transference in adulthood, it's always with you, but it comes out in a really powerful, intense, vivid way when we're in relationships with a very strong asymmetry in power, authority, and in dependency and vulnerability. So when you're in a relationship with someone that is much less vulnerable than you are, that's where these feelings bubble up more powerfully in some way. So examples of them like a teacher and a student. There's a huge asymmetry in power and vulnerability between a teacher and a student. A rabbi and a congregant. That's a very strong, and we have transferences to these authority figures that are reminiscent of how we felt about our parents or other caregivers. And that's why so many Rabbanim are shocked when their congregants are so powerfully hurt by something that they don't even remember saying or thinking or feeling. And maybe they didn't. Maybe it's very distorted. How often have we seen that Rabbanim are just, they've said the same thing to 10 different people, and one person has such a powerful reaction and they're shocked by it. So, really kind of any adult and child, I think this is true. And certainly it applies to psychotherapists and patients. So it's reminiscent of early experiences with parents or other caregivers. The term transference, even though it's always with you, and you can have a transference. So I had a supervisor, he's actually a very famous person. He wrote a number of really excellent books on trauma. He was a traumatologist. Dr. Jacob Lindy, of blessed memory. He talked about transferences to ideas, transferences to the presidential election, transferences to institutions, transferences to everything. But I think that loses a little bit of what it really is referring to, which is when you are in a very vulnerable position, what are the feelings that come out when there is someone else that you really need, that you're really relying on, and they could really hurt you? They could really help you. You're hoping they're really going to help you, but they could really hurt you. And you've come to them because you're in some sort of anxiety or pain or needy state, and you need their help. So that is where the transference is going to come out. And it's true that those feelings color our other opinions. I think it's true that my cousin, who's a communist, is probably a communist because of feelings about my aunt and uncle. I do think that's probably true, but that's not the same thing as how she would feel when she goes to her supervisor for feedback about her first draft of her dissertation. That's going to be a much more intense feeling state. And so in the therapy setting, we try to make use of this. This is information about what the person's deep feelings and vulnerabilities are. That's why the transference is helpful information. That's the idea of the transference. Any thoughts or comments about this? Yes? So the question is, can it happen with peers and spouses? It can happen everywhere. That's what I was referring to when I talked about Dr. Lindy's use of the term more widely. Now, spouse, I will say, I think that we are very vulnerable to our spouses, and that I think that in a healthy marriage, we regress and we want some nurturing from our spouse. Then hopefully we let our spouse regress. We give them some nurturing. If we're so offended when our spouse regresses and we need the spouse to always be the strong one that takes care of us, then that's not, fair, and that's probably a marriage that's going to have some problems. So I think spouses fit into this in an interesting way. We regress in our marriages. We regress in our sexual encounters and our sexual relationships. But with friends, yes, you do make yourself vulnerable to your friends, and therefore your friends can hurt you, so there'll be a transference to your friends. But I think it's different, probably, in peers. The more vulnerable you feel, the more you'll have a transference. The more rapidly you regress, the more you can feel those things. The more needy someone is for validation, for encouragement, for positive feedback, for support, the more they can experience problems in these relationships. And it really becomes relevant when the person who's in the less vulnerable position, who's supposed to be in the supportive position, does something or fails to do something that you felt you really, really needed and you reacted to in a certain way. And you didn't know this in advance. You find yourself experiencing intense feelings in the transference, and you are usually acting it out before you notice it when you're in a transference situation. We're going to go on to countertransference. Maybe this got a little out of order. Let me find... Transference and countertransference. Okay, so countertransference, I think there's a slide missing, and I'll just explain it. Originally meant your transference back to the patient. What is your transference to the patient? Now, you have issues in your life that go with you everywhere you go, and you are somewhat vulnerable to your patients. Your patients, if they don't get better, you feel less competent in your skills. If they get mad at you, you feel bad that you've hurt them. If they're going to speak disparagingly about you to your colleagues, then they can harm your reputation. You know, we do have vulnerabilities to our clients, but if it's a very powerful transference relationship, another thing you're reacting to is their transference to you. So if, for example, let's say Menachem, let's imagine you have a patient who is really hoping that you're going to save him from being bullied by his Rebbe and his father, okay? That's what he's hoping from you. And he's expecting you to stand up for him, and maybe he feels that way because one time you did stand up for him, but in other situations, you're not standing up for him. You're sort of trying to talk to him neutrally about what's going on, and he feels really, really angry and hurt that you don't have his back, that you're not standing up for him. So the relationship becomes, the predominant dynamic in the relationship is he's really disappointed in you and really mad at you. What does it feel like to have someone that you're trying to help disappointed in you and mad at you? That's a strong part of the counter-transference. I apologize for these terms. Like I said, psychoanalysts, they ruin every good idea with terrible terminology. But that's what it means. It means someone is regressing and feeling things toward you. What do you feel like when they feel that way toward you? And it does evoke powerful feelings in you. So what happens with countertransference is that you notice yourself feeling this way after you're already acting it out. So there was a very fine talk in this room last night by Dov Finkelstein, and he gave some really good examples. And, you know, you might defend yourself. You might say, like, well, I can't stand up for you every time you get yourself into trouble. Or you might just be puzzled and not say, you know, like, well, you know, I don't work at your school. Like, I can't call your teacher out and get him in trouble for being hard on you in class. You might defend yourself in some way, or you might find yourself annoyed, or you might feel really guilty. You know, like, oh my gosh, I didn't help him. I didn't have his back. But you're going to find yourself feeling that way. You can't see it in advance. So some things related to the countertransference is something called projective identification. And we're going to talk about projective identification also. This is a term that comes from Melanie Klein, another terrible term, but it's an important idea. This is how I try to explain this term. I've used this in a previous presentation at Nefesh. When you hear a baby crying, what do you feel when you hear a baby crying? What is like the initial reaction? Just out of context, you hear a baby shrieking all of a sudden. Where's the parent? Someone else said something else? Sense of urgency. Hope everything's okay. Stress. Wanting to go pick up the baby. That's the compassionate response, right? I don't know if Rabbi Union remembers his response when I talked about this a few years ago. With the amount of children we've had, I'd have barely noticed a baby crying. That was what you said. Okay. So, and what I said is, you know, the feeling for all human beings except Rabbi Union is terror. Okay? That is actually, terror is what we feel when a baby is crying. I'm not saying it justifies terror, but that is a normal response for a baby crying. And all of your answers were kind of an attenuated derivative of terror. I hope everything's okay. Where's the parent? I need to pick up that baby. Babies are hardwired to cry in a way that fills us with terror. They're really good at this, okay? They're really good at this. And we are hardwired to react with terror to a baby's cry. This is a normal human response. It might be hunger or cold or danger or being like torn apart by wild animals. You know, I mean, that's babies were crying long before, we had beautiful high-rise apartments with no animals allowed inside. This is back from our pre-human history, really. This became our species, human beings, highly social, interconnected human nature. You know, we are really connected to one another compared to all the other species. We are very, very connected to others in a certain way. We communicate our emotions non-verbally and unconsciously, but like the way the baby crying makes you feel a certain way, that's what we do in many other scenarios. If you are feeling sad without saying anything, people feel sad when they're around you. I don't even know if there might be pheromones that you give off when you're sad. There's certainly body language, there's sighing, there's puppy dog eyes. There's all kinds of ways that people can just make a face at you. You've met patients like this. They just induce a lot of feelings of sadness or pity or need to rescue them. Like they do this in a certain way. So Melanie Klein considered this a defense mechanism, the way I could rid myself of my unwanted anxiety. Like let's say you're on a plane and you're terrified that something is wrong on this flight. You will find a way to make everyone else there afraid that there's something wrong on this flight. You won't try to do that on purpose. You will just start telling people this. And if everyone else gets worried, you feel a little bit better, actually. You feel a little bit better. If you're the only one worried, you're going to be much more terrified. That would be an example of projective identification. You are getting others to see or feel what you are feeling, and you're not doing it on purpose. This is unconscious automatic behavior. Yes?
I was just going to ask that question. In this case, if you're conscious, you're terrified. You might not be on purpose. You're getting other people to be afraid. You're at least conscious of your emotion.
So you're actually right. The comment is in that case you're conscious of your emotion. I think actually it happens so fast you're not even conscious of your emotion. I think you are acting out emotion without reflecting on it in any way whatsoever. There is no real reflection on your emotions. You're thinking like, why aren't the wheels down? Why aren't the wheels down? The wheels need to be down. Look, the runway, I can see the runway. The wheels were supposed to be down. I didn't hear them go down. Why aren't they down? There's no distance at all, right? You are acting it out before thinking about it in any way. Wilfred Bion talks about this in a way that I find more helpful than calling it a defense. Patients come in, well, we'll talk about it with babies first. When babies are in distress, okay, when babies are cold and wet and hungry, okay, so a good empathic mother says, why are you crying? And then she feels her baby. She says, oh, you're cold, you're wet, and you haven't eaten in a while. So what she does is she quickly gets on a new diaper. She puts the baby against her bare chest and warms up the baby. And she says, you're so cold, you were wet, you're hungry. And then she feeds the baby. She didn't read the baby's mind. The baby's not crying and saying, the cry is not the baby saying, I'm hungry, I'm wet, I'm cold, why aren't you in here? The baby is just feeling scared and horrible and cries without thinking about it. You are telling the baby that's hunger. Like you're actually teaching your baby these emotions. You're teaching your baby that's hunger, that's cold. When you're hungry, I need to feed you. When you're cold, I need to warm you. You're tired. You need to rest. You need a nap. You're tired. Children don't know that about themselves. When you have a child come home from school screaming, crying, and you have no idea what's going on, and they want you to make them feel better, you say, wait, hold on, back up a second. What's going on? What happened? Everybody hates me. I hate everybody. I'm not going back to school again. I hate everybody. I hate everybody. Okay, you hate everybody. Tell me what happened today. It'll take a few tries. They're going to say that you were on the playground and Yankel got pushed down and scabbed his knee, and Shmuel is the one that did it, but no one saw him do it, and he blamed you, and you got in trouble for it. And everyone thinks that you're a bad boy, and that you are the one that pushed down Yankel and he skinned his knees. And you're not even in trouble. Everyone thinks that you did it. So what does the parent say? The parent says, oh, so you didn't do anything wrong, but everyone thinks that you're a bad boy, and that was very unfair. Shmuel is really sneaky, and he got you to get the blame for it. That is real, oh, I'm sorry that happened. Let's figure out if we need to call your teacher or do something about it. Let's just calm down, we'll think about it later. So what you're doing is the child actually doesn't know what you just said. The child just feels everybody hates him. He hates everybody. He can't get that narrative together. You're putting logical words to that story, and the child is learning how to understand when things happen, it makes me feel a certain way. Another parent might have given a different narrative and might have done something else. So depending on the parent and the kid, they're internalizing sort of different ways of thinking about it, but you're putting structure to their chaos. So the term for this, according to Bion, is containment. You become the container for your child. And then when you put this chaos into words and you give it back to your child in like an understandable way, it's very grounding. It makes them feel sane again. It's very calming. And they learn how to understand the world and that their emotions have an impact on the world. This happens with certain patients in the therapy room all the time. There are many patients that come in furious at their mothers. They hate their mother this day suddenly, or furious at their dad, or furious at their spouse, or furious at their parents. And you don't understand what's going on. If you're a psychopharmacologist and you're not doing therapy, these are horrible cases. Because it's like, is this a new depressive episode? I've got to change their antidepressant? Or no, like I don't know what's going on. So either you have to also be the person's therapist, or you have to really be in touch with their therapist before you make any medication changes, because you're just going to be sort of like shooting in the dark and you'll have no idea what's going on. So I do have cases where I won't agree to be the pharmacologist unless I'm also the therapist, or if I know the therapist really, really well, I know we're going to be collaborating, I know that and I won't make any changes without talking to the therapist first. But those are delicate situations. You get triangulated against the therapist. But I just think that these are challenging cases. But back to cases where the therapeutic intervention over and over and over, hundreds of times for many years, is helping them organize their emotions in a sane way. So each time you put your take on it back for the client is internalizing a little bit of your mental structure. And they're learning to think about things. Now, hopefully not only your mental structure, but there's no avoiding it. They lack mental structure with chaos, and you are going to be the person that makes a mental structure for them. There are many therapies that do that for years before they're able to start really maturing and growing as patients. And that's something that Bion called the container-contained idea. So what I want to say is that projective identification... so how does this happen in the therapy? Patients come in and you are feeling agitated. You are feeling annoyed. You are feeling scared. You are feeling confused. And you don't know why you're feeling confused or annoyed or scared. You have to sort of like, what is going on here? And you have to kind of remember, what did the patient do? What is the patient doing? What is the patient acting like? Why am I feeling this way? And as you put together what is happening with the patient, then you're like, okay, that's why I'm feeling this way. What is going on that the patient is making me feel this way? The patient is making you feel this way similarly to a baby crying. That's what's actually happening. This is the patient's tool for getting help. They sort of vent chaotic emotion, and they need someone to help them make sense of it. And that's what you're going to be doing in the therapy for a long time. What I want to say is it's really not a defense. It's a form of interpersonal communication. We are always communicating with others through projective identification. We're doing that all the time. We notice it when it's pathological, when we're responsible to do something about it, but it's happening all the time. There are certain people, when they come to a Shabbos table, it's just like a bummer. It's like all the fun is just sucked out of the room. It's like a buzzkill. There are other people that like it's going to be a really good time. They make everyone feel good. You know, people have impact on others. That's projective identification. That's what they're doing. What did you say? That's why you stay away from my Shabbos table. Okay. We'll stop inviting you. Okay. So, I want to give another way of thinking about the way these emotions are we pick up on people's emotions. This is called enactment or role responsiveness. So I like the term role responsiveness for enactment. This was the innovation of a thinker named Joseph Sandler. He was a British psychoanalyst and was one of the followers of the next generations of analysts after Melanie Klein. And he did a lot of investigations into projective identification. This is what he learned. The patient has internalized his or her prior relationships as role fantasies. For example, someone has been, I should say, the least favorite child, abandoned, lonely, sad and scared, angry and bitter. That is what this person is used to feeling like. That's always how everyone treats them in the family. Every yontiv, this is like their role in the family. They always feel this way. The patient subsequently constructs fantasies of roles in different types of relationships. Like, I'm going to be... So how would the above adult... Let's just say, what would the above adult want to avoid in relationships? How would that person behave? Someone who this is how they're always experiencing their relationships. What do they want to not feel like when they're older? Say that? They don't want to feel ignored. They don't want to feel invisible, related to being ignored. They don't want to feel rejected. What else? They don't want to feel judged. They don't want to feel blamed, probably. They don't want to feel, all those things. So what do you do if you don't want to be ignored or rejected? What do you do if you don't want to be ignored or rejected? You go to a therapist. That's not what most people do, actually. Okay, so be more invisible. Act out. By the way, it's funny coming from Mark Banchik, because you don't adapt. You adapt in a different way. You become the life of the party. You become the center of attention. That's how you don't get ignored, right? You publish your books. You speak. Not that there's something wrong with speaking. So, but yeah, you might be more invisible. You might be more of a prima donna. Those are different strategies of dealing with the same kind of role. What else might you do? Spend the whole weekend making fun of Nachum. Yes. Take a controlling stance. What do you mean by a controlling stance of situations?
Like, become the person in charge, the one everyone has to look up to, the one who gets everything done, the one everyone has to look up to.
You fill into a leader. You step into a leadership role. In other words, yeah, that would be another very interesting way of coping. But what Joseph Sandler learned is something very interesting. Let's say that someone is constantly trying to get maternal love and support. If someone treats you like a baby who needs a mommy, how do most people respond to someone who is trying? What is the initial reaction to someone who seems inept and helpless and needs a loving mommy to help them? What is the normal response to that? What am I hearing? Annoyance, frustration. Actually, no. That's the secondary. That's because you guys are mean therapists. That's the secondary response. The initial response is you're going to become a loving mommy. That is actually what we do. As a human being. As a human being. The initial reaction, even as a therapist, As a therapist, you know better, so you might stop yourself consciously from slipping into that role because you have boundaries you've set up, you have a professional frame that you've set up, you have things in place, but they're protecting you from your natural instinct. It is normal. When people want a mommy, you are going to open your shirt and start breastfeeding. That is a normal response. Ad kedei kach that we know that women who have stopped producing milk for a while can produce milk for a new baby. It can stimulate them to start producing milk. We know this is actually true. It's ad kedei kach. We do this. We do gratify the roles that we're asked to do. Now, I'm not saying that that's good therapy. I'm talking about natural human instinct. That is normal. That is not something to feel bad about. It is something to notice. It is better. You are much less likely to actually, cross boundaries and become unprofessional if you notice yourself wanting to and acknowledge that you want to. That is normal. When people say, I'm so hungry, I haven't eaten all day in your office, and they see a bunch of crackers with peanut butter that are out on your counter, it is normal to want to give them the crackers. I'm not saying to give them the crackers. If it's a 6-year-old patient, I might say give them the crackers, because we don't expect 6-year-olds to be controlling themselves in the way we do with adults. If it's an adult, it's interesting. And if they do it every time they come in, it's even more interesting. So I know you're not going to do that every time they're there, but you might do it once. Then you might wonder why you did it once, and then when they do it again. But it's normal. That is the normal response. That is role responsiveness. You do unconsciously, automatically do what people ask you to do. This is how con artists con us. This is how scams work. This is how, but it's also how friendships are made and how we fall in love. So it's really just very, very human. And Joseph Sandler noticed this. So we could pause here for a moment. I think there are questions about this.
Yeah, I saw a real toxic example of that. I was in inpatient short-term rehab, and one of the clients was not interested in going to long-term rehab. So we had the discharge meeting. It wasn't my client, it was another counselor, and the counselor was talking about how he's refusing to go to long-term rehab. He just wants to be discharged. And she broke down in tears and just started crying about the fact that this man didn't want to go to long-term rehab. And you need to so much of your doesn't want it, and you should have uncontrollable.
So the comment is someone leaving an acute rehab facility after detox, I guess, needed to go to a long-term recovery program, residential or some other intensive program, and declined the plan at the last minute, which none of us have ever seen before happen. And the addictions counselor or discharge planner assigned to this patient broke down into tears because she was that frustrated / worried / exasperated that all these plans were going to come to naught. This person's probably going to go out and use, and the whole detox and all the plans they made were coming to, were pointless. So you felt that that's an example of role responsiveness because of what? What was the client doing to him or her that made this caseworker or therapist cry?
That's the actual you can never figure out because he never, from the time he got there, was interested in going to another level of care after he detoxed. But for some reason, she probably was some countertransference with him because she just.
Right, so it's certainly right. It's definitely a countertransference to him. This might not be true about what happened. This is for teaching purposes. If that were role responsiveness, what it would be is something like he was always ignored. His needs were always ignored, and he needs someone to finally acknowledge what he needs. So by rejecting the milk, he was basically vomiting out or spitting up the milk that she was offering. And then for her to be so upset and worried that he needs this from her, that would have been a very gratifying response. And that would be her, in that role of being so worried about what he needs. That's what the meaning would have been. If that were true, that would have been her role responsiveness. I'm not sure that's really what it was. Usually, if that's what someone is doing, there's lots of other examples of them doing something similar in the unit. And, residential units are so interesting because there's 24-hour supervision, and there are like a dozen people that get to know someone at the same time, and they're in a regress state with other regress people. So there are so many intense, crazy interactions. So it's a very rich environment to learn quickly about someone's dynamics if you have good staff. Like, they can learn things much more quickly than we can in the outpatient. It makes me very annoyed and envious when someone's in a residential facility and they come out and they tell me things I didn't know about my clients. But they are very rich environments to learn a lot about people. They're moving in with you. It's like you create a dysfunctional family, and you have 12 parents running the dysfunctional family. You have family meetings. There's a Shabbos table every morning, night, and and then everyone processes it together. So they learn a lot about it. They really do. So what is the summary of all these things? Through these kinds of interactions, we realize what is going on inside of our patients. They don't tell us consciously because they also don't know. They're acting out their feelings and their needs and their frustrations and their grievances and their longings and hopes and wishes. They're acting them out with us. We are feeling them emotionally because it's a very messy business. And even though there's certainly a lot of room for error, I think that in a controlled way, doing this a couple times a week for months and months in a row, a really clear pattern emerges. The same thing is happening over and over again. You get to know the feelings. A story comes together that matches stuff in their childhood. You realize that they're having the same reaction to you that they're having to their husband or wife. It's very similar to how they feel about their parents. It echoes their trauma if they have trauma. And it all makes so much sense that it becomes really clear eventually. It goes from confusion to thinking to partnership, and it becomes a very clear pattern. And that's how we do empathize with aspects of the patient that they were unaware of. It sounds messy, but it's actually pretty reliable. It's pretty reliable information. And you do this outside of your clinical settings. You do this with your friends, who you keep getting into the same thing over and over with. You do this with the person next to you in Shul, who keeps having the same enactment with you over and over again. We do this in our relationships. It's just, in the therapy relationship, it's so weird that you talk about it explicitly. You can actually dissect it and talk about it with them. And if the frame is set up that this is how therapy is going to work, patients, it makes sense to them. This really makes sense to people. So it doesn't feel crazy when you're doing this in an organized way with your patients. That's kind of the structure of psychodynamic psychotherapy or psychoanalytic psychotherapy. That's the structure of it. But this is typically the route into empathizing. It's not through detective work and brilliance. It's through emotional encounters over and over and over again, tasting it, smelling it, talking about it with your supervisor, thinking about it, trying a hypothesis with your patient. They reject it. Did they reject it because it's wrong, or did they reject it because it hurt their feelings? Did it hurt their feelings because you were wrong, or did it hurt their feelings because it's right and they don't want to admit this about themselves? And it starts looking messy. It really becomes ordered and sensible. That's really kind of the structure of how it works. Did you raise your hand again?
Yeah, I feel like the tricky and brilliant part is always finding that sweet spot where you move from giving them what they're saying they need to helping them recognize how they can get it for themselves.
Right, so the comment is finding the sweet spot from giving them what they say they need to recognizing, or for them learning that they can do this for themselves. So I guess I don't see it that way in the sense that I don't think that patients come in asking for what they need. I think that they come in acting out what they're afraid might happen or what they want to avoid We don't understand it very well. We try to make, excuse me?
You don't think they ever really need more of that if they were abandoned as a child, right? And they're still there, 17, 18-year-old, and they're looking for attention.
The question is, do they actually need attention and need care? I would say that no, they need treatment. I think that this is long after parenting was over. I don't think we're going to become parents. I mean, look, I was involved in a situation in my community where there was a mother perpetrating Munchausen by proxy against her children. They needed foster care. We became foster parents. I had a friend who was in CFS, at CPS. We became foster. That wasn't treatment. That was foster care. But if someone is coming into your office and they have parents, not all those kids are being abused by their parents. If they're being abused, we alert the authorities. But there are a lot of children that have difficulties. They have an anxiety disorder. They have a mood disorder. They have ADHD. They have parents that are really doing the best that they can. And they need treatment. And I'm also talking about adults where this is long after parenting is over. I don't believe in reparenting. I don't think we can reparent our clients. I think that there's, I'm going to use a metaphor. There's a certain age after which if you learn a new language, you're going to have an accent. You're not going to be a native speaker of that language. And I think that happens with personality development. I think that there are certain things from childhood that we can't redo or get rid of with parenting. I don't think it works that way. And I don't think that they're asking, I think they have wishes, but there's a difference between wishes and needs. We can't really gratify their needs. It's not our role. Our role is a therapist. They can have their needs gratified by a lover, by a spouse, by friends, but not entirely. Those relationships are not reparenting relationships either. I don't believe in the corrective emotional experience. I do believe in an unprecedented emotional experience where they're going to learn to experience themselves in a new way, think about themselves in a new way, learn how to be in a relationship in a new way. But it's not because you're a nicer, better person. It's because the boundaries of therapy are really weird. You don't have any needs from them. They have to show up and pay their bill. And that was in, ascending order of needs. That's what you don't need them to be helpful to you. You don't need them to gratify you. I mean, a little, because we're all narcissistic and needy a little, but that's not, a lot of your patients you would not enjoy being friends with. You wouldn't. And you wouldn't be friends with them. Some of them you might have been able to be friends with them had you met them socially after treatment. Some of them you might have been able to be friends with had you met them socially before treatment, but you didn't meet them socially. You met them professionally. You're not going to be their friend. And you're not going to be able to offer them the healing that a friend relationship offers. That's not what you're doing. That would destroy the therapy, and you won't like them as a friend. If you've ever tried to have a friendship with someone that was your patient, they're the worst friendships in the world. What they just want is constant empathy and feedback 24/7. And you don't want that. You want friends that are peers and are going to be there for you, and it's going to be mutual. That's not the relationship. So the reason that they learn about themselves in a new way is because the therapy relationship puts no demands on them, or very minimal demands on them. They're not doing that for you. They're doing that for themselves. So I don't think that I agree that we're fulfilling their needs. We're providing the best treatment we can. That's the only need really we're gratifying. There are some exceptions a little, but I think that that's basically the role that we're in. And if they need something, if they need foster care, if they need friends, if they need, we tell them, why don't you try to go on meetup.com, the Cincinnati version, and find some other people that like writing, and you'll go to a writing group, or you'll make suggestions for how they can socialize, but you can't do that for them, and you won't become, there is a time during therapy that you may well be the most important person in that patient's life. That is true. But the reason that's true is because of the lack of other important people in their lives, and that you're the only one they can have that kind of relationship with right now.
You do have to fill that need, not forever. But there are cases where you have to first give them what they're asking for, even just the filtering
So I think the comment is no. There are even moments where you are fulfilling that need with a relationship. This might be semantics, but for the clarification of what I'm trying to say, I'm going to again disagree, because you're not providing a relationship, and now that they had a relationship with you, they can try one with someone else. You are providing treatment. The treatment is a relationship that allows them to experience themselves in a new way, but it's only because it's not a social relationship. It's a professional relationship where they're not asked to be your peer or do anything for you. That's why they can get away with curling up on your floor and crying for an entire session. And then you still have to get them out of your office, and you're worried about what you're going to do, and you have to repair that. But you won't do that with a friend. If people would do this in your home, like as a guest on Shabbos, you're not going to invite them back. You're not. You can't have that in your house. There are some people that are a glutton for punishment, or they have a... Yeah, that wasn't my patient. I was a foster parent. Well, on one occasion, I was a foster parent in my life, but I'm distinguishing between that, and I could never be their doctor. I could never, ever be their doctor. I'm sure other people have done things like this socially. We've given tzedakah before. We don't give tzedakah to our patients. You shouldn't. There are other people to give tzedakah to. You should not give money to your patients. I'm sure you all give tzedakah. We all do mitzvos, but if you're providing treatment, that's really what you're doing. It's your professional role. So I think it's somewhat terminology, but I don't believe that we're providing for their needs. I think that we're seeing people that can't get their needs met socially, and we're trying to figure out with them why they can't and help them live life differently so they can, but we're not the ones that are going to fulfill that for them. Yes, Yitzi.
Maybe I would just say it this way. There might be a period where we might inadvertently be gratifying our patient's needs, but that's not our role. That's not our intention.
Well, it's not the law.
And if that were to happen, we might actually want to explore what that experience is like.
Right, so the comment is we might actually be inadvertently, fulfilling their needs. We laugh at their jokes. They feel they have a good sense of humor. No one else laughs at their jokes. That's an example. It's not bad to laugh at their jokes, but if they're not funny, you probably shouldn't laugh at their jokes. Just because they have a need to someone to laugh at their jokes, Yeah. So there's some other hands. I want to just get to a little bit more material. Maybe I was going to give a clinical example, but maybe I will just allow for questions right now. I think we'll go ahead with questions. Another one in the back, yes. So it's a very profound comment that one of the, I'm going to paraphrase, you'll tell me if I'm right, one of the profound needs people have is not just to feel loved, but to have their love accepted by another person. That's really a profound need in many other people, that my love is valuable to someone else. And that ultimately can't really be what the clinician is doing for them. You can't be their lover receiving their love in a way that fulfills you as a person. We all need to have people that feel fulfilled by our love, to feel like whole people in our lives. Your clinician cannot be the person to do that for you because they are just another client paying their bill. And that's one of the things that's so sad for patients is, am I just another client to you? Am I just another client to you? The answer is, of course, yes, actually, but that doesn't mean that you're not having a very profound, life-changing experience with them. There is a really interesting paper. It's called A Home in the Mind, and it kind of turns relational psychoanalytic theory on its head. and it says the following, that if you're coming to see me for treatment, one of the most profound things I can do for you is actually reflect to you who you are to me. And that when you learn who you are to me, that's actually how one of the ways you learn about who you are as a person and what you can do. But it's still a clinical relationship. So you're not going to ever be to me what you can be to your spouse or to your lover or to your child or to your best friend. You can't be my best friend if you're my patient. That would not be treatment. It won't work. I won't feel about you that way. And I'm not treating you or expecting from you what I would need from my best friend. My best friend has to do a lot for me, more than you need to do. Yes?
How would you be able to even understand how your client is to you in any sort of normal social paradigm?
How would you understand what your client is to you in a normal social paradigm? I'm not sure I understood.
I'll give you an example. One of my clients is a master gardener, right?
Mm-hmm.
He's a master gardener. You can ask him 10 questions about molecular plants or whatever. I don't know anything about that. So to me, when he comes in my office, he's my client with whatever needs he came in with, and he's also a master gardener. Is that what you're referring to? Or is it something else? Because I don't see him.
I apologize, but I don't think I understand your question. I'm sorry.
I don't see the comparison at all. Like, that we can show him who he is to us.
Oh, how can we show him who he is to us? Okay, so I'll give a clinical example. So over time, I think my patient has realized that I think he has some interesting ideas. I think that he has some crazy ideas. I think that he can be sensitive and helpful. I think he can also be a jerk and nasty. I do enjoy his presence. I would say all the clients that I work with long term, I start to enjoy their presence over time. I don't think that's only self-selecting. I don't think the people that I don't enjoy are dropping out. I think that I think that a lot of time with someone you do learn to love or like them in some way. And they do get a sense as to how I understand them, how I think about them. And we always talked about how I become an object in their mind. But no, they see that they're an object in my mind. And actually, if you think about the people that are so meaningful to you in life, you know what's meaningful? How they think about you. The fact that they think about you when you're not there. The fact that, it's not meaningful to you that they show up in your dreams. It's meaningful that you show up in their dreams. That's meaningful to them. I'm not saying that you reveal that to your clients, that you had a dream about them, but we do dream about our clients, by the way. That's a normal thing. But they get that. They get that that they have become a person, and you don't tell this to them in an essay form or write up a summary of how I feel about you, but they learn to understand how you feel about them, and the more close, empathic, informed, skillful clinical care you've provided, they have an even better idea as to how you think about them. It's not that you're just making a space for them to blossom and you're not part of it. You're really part of it, and they get to know who you are. Now, I'm sure that your master gardener, I'm sure that you couldn't hold back but ask them how to get your tomatoes to stop wilting, or I'm sure that you ask them questions like that, and that's fine. That's probably actually not the biggest deal. It's a bigger deal that they realize that you have opinions about them, and they find your opinions meaningful. They actually like how you think about them. They wouldn't be coming to see you if they didn't like how you think about them, including when you're critical about them. They think it's valid. So I think that patients do learn this about us over time, but it's only because we were clinicians. It's not because we became friends. Now, they needed this kind of scenario. By the way, we have some clients that are very skillful socially. They have a lot of friends. They have great relationships, and they need a different kind of treatment. But I'm talking about people that really have I think the questions have been about people that really have impoverished relationships. They're very socially isolated. They really have no one other than us. If they're going to move beyond us, there is a time that this relationship is the only one, but it's not the healing effects of our love or it's that they're learning how to dialogue, to think about themselves, to get feedback. We can give them feedback that other people can't give them because other people are infuriated by them because they're causing problems for them. I have a patient who ruined the wedding of his rabbi. He had a single rabbi who got married, and at the wedding, he ruined the wedding. He made a spectacle of himself at the wedding. He expected to be at the dais, the head table, and he wasn't. And he had an absolute tantrum, and he collapsed and fainting on the floor. 30 minutes left is what that says. Thank you, Lisa, for the extra time. Lisa's so flexible with giving us extra time. So he fainted. We're all starving. We haven't had enough food. So he fainted, and they had to call medics to the wedding, and he never got invited. Now, he did stuff like that in my office, too. But that didn't disrupt treatment in my office. He fainted in my office when it was time for him to leave. He said, I don't want to leave, and he fainted, and he didn't want to leave. He would stay in my waiting room for 30 minutes in a row of a 45-minute appointment and mad at me for telling him to get out of the waiting room because it was my fault that I put such interesting books in the office. He couldn't stop reading them. He wanted to borrow my books. I said no. All kinds of things he did. So he can do that in my office, but I wouldn't want him at my wedding either if that's what he's going to do. So I don't think he's still in treatment. I don't think he's going to do that anymore at weddings. He's a lot better. But I don't think that it's my love that's helped him. I think it's my really honest feedback, reflecting on stuff, realizing things, acting it out with me, talking about how he acts it out with me, understanding what he's looking for. I do understand what he went through. It does make me more tolerant when I can see the purposes, but it also, he can talk about it with me rather than acting it out. This is long, tedious work. And that's what makes people better. It's the interventions in a relationship and how they learn, but it's a weird relationship. The relationship is defined, it's only possible because of the clinical parameters and the weird boundaries, that it's not a real friendship. We're not friends, we're doctor and patient, therapist and patient, and that gives them the freedom to be themselves without all the consequences they have other places. But I'm not nicer than that rabbi. I'm really not nicer than that rabbi. I just don't have the same needs that rabbi has. If he thinks that I'm nicer than the rabbi and that's why he can talk to me, we need a lot more treatment. That would be a treatment failure if that's why he thinks he's getting better. He has to understand that can't fly with any other people. It flies with Dr. Klafter because he pays Dr. Klafter. And Dr. Klafter's paid to put up with this. And Dr. Klafter's weird. He likes this. Most people don't like this. But that won't work in other settings. And patients do really have to understand that we're not, no one will do what we're doing with them. No one will, and that's not because we're nicer people. We're not better people. We're not more understanding people. We're paid professionals. So that's why, the smells that a gastroenterologist has to put up with, I don't want to do that with friends. I doubt they want to do that with friends. That's what our job is sort of like. That was an interesting metaphor. You can take that for what it's worth. Yes.
She mentioned working in the trans community. I'm a gender therapist, been a gender therapist for 10 years now. And there is a group called therapyfirst.org. It's therapists that do not work in an affirming lens. So we don't do gender affirming care. And it works alone.
So, I'm just going to, I just don't want to start having a promotion for another organization or entity. I understand, but I think I'm not going to repeat that I don't want to do that right now. No, I actually don't want to get into this right now, thank you. Any other comments? Yes.
Just in short, you have got me really thinking.
It's
would make that the child would have to act to me as if they're my child. So I think
So I think the common is that we use certain terms from our other relationships, but it's a metaphor because that's how we think about people. It doesn't capture what's actually happening. Like we're not, we're in an imaginary space where it's as if we're teacher and student. It's as if we're parent and child. It's as if we're brothers. And we can imagine that together, but we're not becoming brothers. We're not becoming parent and child. It's just because those are the terms we have for how we relate to people. And those are better terms than the analytic terms, so I don't blame people for using them. So I think we're at the end. Thank you very much. I enjoyed sharing this with all of you. The recording's on, and you can still ask me a question. So nice of you to come. It's great. It's been a long time. Thank you for participating. 100%. Yeah.